Good to go, ma'am.
Good evening, everyone. A very warm welcome to all in this session of ACP India Chapter Case Files, a John Tucker Evergreen Award winning series. Today, we have a panel of experts who are outstanding in their respective fields, and I am sure that they will enhance our knowledge. But firstly, I would like to welcome our respected governor, ACP India chapter, Professor Dr. Anuj Maheshwari, sir. I would request, sir, to say a few words before we start with the sessions.
Thank you, Preeti, and welcome to all attendees. My greetings from ACP India chapter to all those who are attending from India and from abroad. As Amit has informed me, we are completing today 2 years for this wonderful program, which has won the John Tucker Evergreen Award in ACP India chapter Chicago meeting. And this program has been quite unique, which has given insights to our early career physicians regarding their clinical knowledge as well as their personal well-being, their personal upliftment, may it be related to the ethical issues, may it be related to the financial issues, and may it be related to the other kinds of the things which they may need in their day-to-day life. So we are trying to help them through these kinds of the programs. We ask some of the very senior professors to present his lifetime memorable clinical case which he has went through in his clinical days and experience.
YouTube કર્યું.
RX event, please kindly mute yourself. So we always request in this program to a senior professor to present his experience of managing a difficult case in his lifetime. And they do it and share their way of handling the patient in that difficult situation to our early career physician, which usually becomes quite learning for all of us. And even those who are in their advanced stage of their clinicians life, they may also be benefited of these experiences. So without wasting much time, I will request Dr. Preeti, who is conducting today's program, to take us forward for this program as per the schedule. And I hope this program of the series shall also be liked by our attendees. This is 24th program in the series, and we shall be continuing with this series in the next, at least next 1 year or 2 years must be. Maybe some changes can be suggested if it is required. So you can always give us the feedback regarding the program. Over to Preeti.
Thank you, sir. I would like to introduce Dr. N.K. Singh, who will be moderating this session. Dr. N.K. Singh is Director, Diabetes and Heart Center. Sir is Chairman, RSSDI, Jharkhand. He is the Executive Member, National RSSDI, ex-governing body member, API, Chairman, API, Jharkhand. He is editor and associate editor of many reputed books and has over 40 national and international publications. Over to Dr. N.K. Singh, sir.
Good evening to you all. Actually, I have to connect with 2 devices as video is not coming. First, a great thanks to Dr. Anuj, Dr. Amit, Dr. Preeti, and our both learned speakers today. I think today, without wasting time, Professor Dr. V.K. Goyal is well-known physician in India. And I think at Udaipur, he is doing a marvelous job by doing so many research works and other things. He's also the American International Institute of Medical Sciences, Udaipur. He's running. Publications are more than 40, editorial board member and reviewer to many journals, got many lifetime distinguished awards, and also fellow membership of many bodies. So I think today's case is very, very interesting and very common too, because in our clinical practice, we get such cases. So first we will go for Dr. V.K. Goyal to present the case, then we will discuss the case. So, Dr. Birendra Kumar Goyal, can you start, please? Thank you.
So, thanks, Dr. N.K. Singh, sir, for kind words. You are a well-known academician in the country, and you are running a very good WhatsApp group also, CME, in the form of CME India, and we are learning daily from him. And thanks, Dr. Anuj Maheshwari, Dynamic Governor, Dr. Amit, Advisory Council Member, Dr. Priti Singh, ECP Council Member, for giving me this opportunity. Dr. Priti, can you, because you have disabled my participating screen, can you make it able? It's mentioning host disabled participating screen share.
Sir, you can share your screen. Try to share.
Disable from the host side. RX people can make it.
Sir, now you are co-host, sir. Try to share your screen.
I am trying to share, but every time it's. No, I think, sir. So, Dr. N.K. Singh has already mentioned about it. Let me come to my.
So we can see your screen.
Yes,
Yeah.
visible. It is visible.
So kindly start slide share.
Slide share I have started, but there is some. Is it?
Yes, sir, it's visible. Yes, it's moving and visible.
Yeah, there was some probably hang. So let me start. I'll be talking of, I have given the heading in the beginning, and after case discussion, probably I may change idiopathic conjugated hyperbilirubinemia, or what we call as idiopathic direct hyperbilirubinemia. There is no disclaimer. I am sharing a patient which I have discharged only last week. The patient was with us for 10 days. So this is all about the patient. 35 years old, married male, Ukmi Chand, resident of Udaipur, vendor by occupation, came to my hospital on 18th of this month with complaint of diarrhea one day, fever one day, generalized weakness one day. All history was 1 day old. Patient was all right 2 days back because he started traveling from Mumbai to Udaipur 2 days back. Then for 1 day he had 2 to 3 loose stools, 100 to 200 ml each episode, watery in consistency, foul smelling, yellow in color, exasperated by activity and not relieved by any medications or food. It was not associated with abdominal pain, vomiting, melena, or hematochezia. Patient traveled, as I said, from Mumbai to Udaipur 2 days back. He also had a fever, which was sudden in onset, and one episode of high-grade fever I noticed in the ward after arrival of the patient, and I recorded it as 103°F. It was only one episode that subsided with the antipyretic drugs. Common antipyretic drugs, what we are using commonly is paracetamol. Fever was associated with marked generalized weakness. That was after episodes of loose stools, and he was unable to do his daily work since then. He complained of not going to even washroom of his own because of marked weakness, and there was no history of altered sensorium or headache. On further taking the history, there was no history of hypertension, type D, tuberculosis, diabetes mellitus, asthma, and there was no history of blood transfusion in the past, no history of long-term use of NSAIDs or other drugs. Family history, no similar complaint in the family was noted. He is a chronic alcoholic for last 5 years with complete abstinence for 2 months and occasional opium consumer. He has got a vegetarian diet. Sleep was reduced in these last 2 days. Decreased appetite and bladder bowel were normal. Conscious and cooperative patient on examination. Patient was sitting on the bed at the time of examination and BMI was around 29.8, means slightly overweight. Hydration status, he was hydrated, pulse 92 beats per minute, BP was on the lower side, 80/46, respiratory rate though was normal, and temperature at admission was 98.6, and as I mentioned, the next morning when I saw, it was 103. SpO2 room temperature 96. On general examination, pallor was absent, icterus was present. No cyanosis, clubbing, palpable lymph nodes, edema, JUP not raised, and this is the build of the patient, and this is the patient. And these were the eyes of the patient, showing clearly yellow discoloration of the sclera. Systemic examination, we found CNS, CVS, respiration, per abdomen examination, all were normal findings or no abnormal finding was noted. In getting investigations in 3 sequential order every alternate day, the day 1, hemoglobin 11, counts 4,000, platelet 60,000. Create 1.7, urea 88, electrolytes were normal, and PBF did not show any abnormality in the film. Normocytic, normochromic, normal counts. Platelets on one day after that, on 20th, 192,000, which raised to 1.86 lakh on 22nd May. And the create and urea after one day came to normal range. Surprisingly, when we observed the jaundice in the eye or the bilirubin, day 1 it was 3.0 with direct 2.91. OTPT alkaline phosphatase were normal. On 20, means one day after, we got the bilirubin done again. It was 5.7 and direct was 5.01. OTPT alkaline phosphatase again were normal. And as I mentioned earlier, the create and urea which were high on the day of admission, means 18th, were they came to down to normal on date 20th. Bilirubin again was done after one day. Interestingly, as there were no other findings, no other laboratory findings, because KFT came normal and LFT only bilirubin was raised. We got it repeated again and it was 5.15 with direct 4.94. OTPT alkaline phosphatase were normal. Interestingly, we got LDH, ceruloplasmin, and urobilinogen. Those were almost within the normal range. So, coming to discussion, we are hereby having a case of idiopathic direct hyperbilirubinemia. All other liver enzymes are normal except raised conjugated bilirubin, that is direct bilirubin, and no history of any long-term drug intake. So icterus was present. On getting detailed examination from the patient and his wife, they were quite literate enough to answer our questions. Icterus was present since 1 year, as noticed by patient and his wife. This is the serum picture which I have taken from the laboratory after centrifuging the blood of the patient on 22nd, means on the third sample. And this is the screenshot I have taken from the machine in which the bilirubin was recorded in the laboratory, that it was 5.56. So we are discussing here.
Dr. Goyal, before proceeding further, let me ask you, why did you go for the ceruloplasmin test? What was the indication of doing that test?
because we just wanted to rule out all other causes of hyperbilirubinemia, including Wilson's disease.
So you thought about the Wilson disease.
So,
And did you think about the viral hepatitis? Yes. Any thought about why it is not viral hepatitis? Oh,
the study was short, that the prodrome was not long, and the diarrhea and fever subsided within a day. Number one. Number two, viral hepatitis I never thought, because OTPT was all the way normal. In case of viral, if it would have been viral hepatitis, then OTPT could have been raised. And patient didn't have any episode of vomiting during this full course. So coming to isolated hyperbilirubinemia, there are two types, indirect and direct. In indirect, we have hemolytic disorders, ineffective erythropoiesis, increased bilirubin production in cases of massive blood transfusion, resorption of hematoma, and notorious drugs causing indirect hyperbilirubinemia are rifampicin, probenecid, and antibiotics like cephalosporin and penicillins. Inherited conditions where indirect hyperbilirubinemia is seen are Crigler-Najjar, type 1, type 2, and Gilbert, as we all know. And direct hyperbilirubinemia, which is a rare condition, is a inherited condition, is seen in Dubin-Johnson and Rotor syndrome. I have seen in the literature that very few, maybe your experience, moderator sir, can enlighten us, less than 100 cases have been reported of the direct hyperbilirubinemia. So this is an algorithm to explain my patient. So overwork in a patient of jaundice, when we go with the history, we focus on meditation, drug exposure, physical examination, and lab test, as I mentioned, focus on bilirubin, with fractionation, means direct and indirect, or what we call is conjugated or unconjugated. ALT, AST, alkaline phosphatase, prothrombin time, and albumin. When there is isolated elevation of bilirubin, as in this case, because other liver tests were not elevated in all the three recordings during hospitalization. So we come to isolated elevated bilirubin, where we get either direct or indirect, means either unconjugated or conjugated. Unconjugated, as we have seen, rifampicin and probenecid are common notorious drugs. Inherited disorders, as I just mentioned, Gilbert, Crigler-Najjar, and hemolytic disorders or ineffective erythropoiesis. Our patient was having 90 to 95%, rather more than that, of direct of conjugated or direct bilirubin was more than 90 to 95%. So we have got only two inherited disorders like Dubin-Johnson syndrome or Rotor syndrome. This hole on the right side of my screen, we cannot raise any suspicion because LFTs, including AST and ALT, from the day 1 to last, means when the patient was discharged, well within the normal range. So now my patient, I can say, is a genetic conjugated hyperbilirubinemia, and two conditions which I mentioned, one is Dubin-Johnson and second is Rotor. Both are autosomal recessive disorders. Total bilirubin conditions concentration usually remains 2 to 5, and in rare cases it can be 20 to 25 milligram per dl. The liver may be grossly black in appearance when the bilirubin is very high. Rotor is again an autosomal recessive condition, but in both the conditions, whether it is either a Dubin-Johnson or a Rotor, definitely my patient was a genetic hyperbilirubinemia, idiopathic or genetic. Only once when we get a genetic study, which is not being done in my state, and I plan to get it done when the patient comes back for follow-up after 10 days. Then I plan to go for a genetic study if I again find the same LFT conditions. This is all about. Thanks for patience hearing. Now I request Dr. N.K. Singh, our moderator, to please speak, enlighten us regarding this case.
I think, Dr. Goyal, you have done a wonderful job by presenting this very interesting case. And whatever you told, that whenever a case of hyperbilirubinemia comes to us, you go for the history, physical examination, then you do the routine LFT. That is most important. And suppose the LFT is normal or abnormal, that makes the further approach of any patient. Suppose it is normal. Judge, you told that here the SGPT that you did here was normal. So we didn't think about the viral hepatitis or any suspect the liver damage. And you thought about the familiar hyperbilirubinemia which you got unconjugated. Maybe sometimes you get also the conjugated and sometimes unconjugated. So I think how to approach from this place, it becomes very tedious and very difficult for general physicians. But simplifying the things, you sort now on the approach of this case, that suppose you get an conjugated hyperbilirubinemia, then you go for the serum bilirubin. Suppose it is 2 to 6 milligram. And did you go for also this urinary coprophyrin or isomers like 1 and 3? Because sometimes that gives you an insight to whether it is suffering from the Rotor syndrome and Dubin-Johnson syndrome. It is very difficult for go for very invasive test or going for genetic panel test, as you are told yourself. So I think this doing a urinary test with the corporoporphyrins, that is some isomers are, I think, 2 or 3rd. Suppose you can have either Rotor syndrome and Dubin-Johnson syndrome, and final bit, you have, if you want to confirm it, you will have to the liver biopsy. That is important. But suppose in this case, where bilirubin was around, I think maximum was around 6, and you go for suppose the hemolytic test, that becomes very important. If it is an unconjugated bilirubinemia, then you go for the hemolytic test. If it is positive, then definitely we go for to suspect the hemolytic disorders. So it is very simplified. And then suppose it is the negative, then we again we again go for the bilirubin. Then suppose it less than 5, then basically you think about the Gilbert syndrome, or then you go for the genomic testing if needed. Sometimes how to differentiate between the Gilbert and Crigler-Najjar? Can you give some insight on that again, Dr. Goel? How to differentiate between from this place to the Gilbert and this Crigler-Najjar syndrome? Because the patient has been unconjugated, then the hemolytic test has been done, it is negative. Now the question is whether it is Gilbert or the Crigler-Najjar. Then how to go for that?
Because my patient was not of a unconjugated hyperbilirubinemia, so I never had these things in my mind.
But suppose I am telling this is a different part. If your patient was basically from this conjugated one,
yes sir.
But suppose if you get an unconjugated, then how to proceed? Because then we think about 2 things. Whether it is the Gilbert syndrome or Crigler-Najjar syndrome, because one is a fatal condition. You know, the Crigler-Najjar is a fatal condition, where I think this Gilbert syndrome is not so fatal. So I think very important here, even in that case, suppose you got it, then how can you say how to differentiate both cases? I think there is a simple way to proceed is you do a serum bilirubin again here. If it is less than 5, confirm it again, and then you basically think about the Gilbert syndrome. And suppose it is something around, because in that case in Gilbert, the bilirubin level is less than 5 usually. But if it comes around 6 to 25 or more than 25, then you should think about the Krigler-Najjar syndrome. And then again, we have to go for the genomic testing. So this part should be quite clear. That suppose we get a hyperbilirubinemia unconjugated, how to proceed? And when you got an conjugated, then I think, did you go for the urine testing for this this code profiling? Is it available there?
We don't have this facility in our city itself.
But I think that is important test. If you do it, then I think you can have some insight for the rotor and the Dubin-Johnson. So basically, you think about this is an idiopathic case.
No. Initially, I started the case as
Yeah.
a diarrhea, fever, looking to tropical fever disease in this area, coming summer season. But coming to this all laboratory finding, we cured the diarrhea and fever, and finally we came on the conclusion of direct hyperbilirubinemia. And in this, we had got only two things. And to add one thing more to my patient's prognosis and diagnosis, that both the conditions, Dubin-Johnson and Rutter, both are benign conditions. No treatment is needed for the patient. The patient remains lifelong with this high bilirubin without any damage to the liver or other organs or his body functions or his routine work.
Yeah. So what were the initial presentation? Do you think that the both this syndrome, whatever you are finally you went for the final diagnosis, why was it so much of the acute presentation? Was it related to this condition or was it separate one?
No, sir. These conditions are benign. They don't have any acute presentation during any course of the illness. Rather, it was associated with traveling in summers, having eating some food, having a diarrhea, and having a single episode of high-grade fever, which I take is either travelers or a tropical diet. Tropical.
So,
and that
so that point is now quite clear that the initial acute presentation was something different.
Definitely.
And then you got the history that the icterus was for the 1 year.
Yes.
Then you
I took this history after taking the repeated bilirubin high levels.
Well, then I think now the things are quite clear, and the most of the points, I think the most important point is how to approach of these such patients. And I would finally, I think, end this session by saying that not in all cases we go for the genetic or genomic testing. By simple history, by simple doing the lab test with starting from the SGOT or LFT, and accordingly seeing whether it is unconjugated or conjugated, and accordingly whatever I told you and that approach as we can screen has shared, I think by proceeding in that way, we can have a clear-cut diagnosis about rather it is a rotor syndrome or something like that. And accordingly, we can say about the prognosis. That is very important because around to predict the prognosis. So I think this time is up for his presentation. So Dr. Pratik, can we have any? I don't see any question in the chat box. Do you have any question?
Sir, I wanted to ask, how do we explain this thrombocytopenia in this patient?
Very good question, Dr. Preeti. I am really impressed. Thrombocytopenia was initially there. We had 60,000 count in our first report from the laboratory. That raised to 94 or 96,000 one day after, and that came to 1.84 lakh again one day after. So thrombocytopenia, I myself relate to tropical fever disease, which he had, as I said, a episode of very high grade fever, subsided with paracetamol. For thrombocytopenia, I have never given anything extra, means any RDP or SDP, because it was already 60,000, so not alarming to me. as far as patient symptoms were concerned. They got an improvement itself after alternate day testing done. And 60,000 was never alarming.
Yes.
So yeah, that was an important question. Dr. Preeti, thanks for sharing it.
I would
Dr.
also
Gupta,
like
do you
to,
have any comment?
sir, yes, I would like to make 2-3 important observations here. Sir, it was very important initially to take the detailed history. Because if you look at the patient just from the acute presentation, then there was a very good chance that it could have misled us to a different type of investigation, different type of diagnosis. Also, that having a history of some kind of jaundice persisting almost for a year, also the patient was having some kind of chronic alcohol intake, that probably also warranted the detailed investigation which has been done in this case. Because it may not be that straightforward to say that it is simply not because of the other reasons. We also know that sometime in a tropical fever, what may happen that liver enzymes may come down even earlier, but the bilirubin may remain elevated also. So this kind of presentation may also happen. So I think this was a not that easy to crack case, thinking of different possibilities. And we know that direct hyperbilirubinemia is not a very, very common entity. And as Dr. V.K. Goyal has already pointed out, that there are only less than 100 cases which have been reported all across the world. So I think this is a very good learning for all of us. Thank you very much.
I think with a great, Dr. Goyal.
I want to add one more thing, sir, for the knowledge of all persons in the country, that from this belt of Rajasthan, from Ajmer to Udaipur, most of the workers for their earnings are moving to Mumbai. My patient has come down from Mumbai to Udaipur. So what the persons are doing there, they are either cobblers in Mumbai, or they are cooks in Mumbai, means doing cooking business, or they are drivers. So first of all, any person with any vague symptoms, if coming from Mumbai, maybe acute or chronic, I'll go for triple S done. I got in this patient also, and it was all the way negative.
Yeah, I think, thank you, Dr. Goyal, Dr. Preeti, for raising one very important question, Dr. Amit. And I think with great thanks, I will close your session here, and then I will invite the next speaker. So I think now something different from the medical world, but very important for us also. So I will request to please unshare the screen, Dr. Goyal.
Yes, sir.
Can you please? Yeah, thanks. So now I invite very brilliant Dr. Mr. Siddharth Garg. He is CA, FCA, LLB, ISA. He is practicing as a chartered accountant in Delhi since last 19 years. He is from the prestigious Sri Ram College of Commerce and is a direct taxation and financial expert. He has previously worked with KPMG in their corporate direct taxation practice. So, Dr. Garg, can you start your presentation? We will take questions later on. Dr. Garg, Mr. Garg, sorry.
Thank you, thank you, Dr. N.K. Singh, Dr. Preeti, Dr. Anuj Maheshwari, and Professor V.K. Goyal and Dr. Amit Gupta for giving me this opportunity. And today's topic for the presentation is basically financial planning for medical profession or doctors. So from what we have gathered, from what we have seen, is that the medical profession as such is a very challenging profession from what we see. In the early years of your studies, it takes a lot of time. Then again, I think after your graduation, post-graduation is also a must. And after that, maybe if some of the doctors want to go for super specialization also, then I think it takes another 2 or 3 years, if I'm not wrong. So from what we see is that during all this time, all the doctors are majorly engrossed in their studies and gathering expertise of the medical profession. They don't really get the time to think about their finances and how to sort of invest and save their money for the future, for their professional commitments and for their family. So somewhere I feel that in the medical profession, this knowledge remains missing. So I would like to bridge the gap a little bit, or maybe make you guys all a little more aware about the financial aspects of the profession and life as such. So I think I'll start with the presentation.
Please, yeah.
Are you able to see my screen?
Yeah, you can see. Yeah, fine. You can go.
Okay. So majorly, what we see that financial planning is basically planning about your future and planning about your finances over the period of your life. So basically, it has some steps wherein we will discuss all of them. So firstly, what I would like to say is that the journey of 1,000 miles begins with a single step. So somewhere along the line, we really have to take some steps, or maybe we have to start taking steps towards our financial planning so that we don't have to think about money when we grow old or when we don't want to do practice, as in the case of doctors. So now is the time. The basic point is that we should start as soon as possible and not sort of delay it to do it later on when we are earning more money or when we are more comfortable in our life. So the right time to invest and the right time to take steps about financial planning is now. So basically what the challenges faced by the medical profession are that, like I have discussed, this career starts late. The career takes off around 28 to 30 years of age. The work schedule of the doctors is very demanding and they do not really get time to think about their finances. And from the my limited experience of dealing with doctors or talking to doctors who are my friends, some of them really do not actually want to talk about finances. They do not want to look at their bank statement. They do not know anything. And they do not want to address that aspect of their life at all. They just want to, because from what I gather is that they really do not have the time. The medical profession as such is a very challenging profession. Like in the morning you do OPD, sometimes you have your own clinic, then you go there in the evening, during the afternoon also the doctors are visiting somewhere or the other. So I really feel that the basic point that is missing here is the time. So secondly, the second decision that the doctors usually have to take is whether to do job or to get into their own practice. I understand the job basically gives you a regular stream of income and a specific amount will come to your bank accounts every month. But as far as starting your own practice or opening a clinic is concerned, I think it might be more challenging and there might be more things to take care of. But in the end, I think it gives you more money and gives you more freedom to manage your time in your own way. And third challenge that the medical profession faces is during the whole of their career and whole of their studies, they're not really taught about the financial aspects of things, how to manage their own clinics, how to budget, how to think about the cash flows, how to do investments so that later on they don't have any money problems. So these are basically the challenges that the medical profession faces, and due to which it becomes all the more important for doctors to start their own financial planning very early on in their career. Even though I feel even after graduation, I think some of the doctors go into internships with the hospitals during their post-graduation. Also, they get some money, or I don't know what they call it, a stipend or a salary. But I think a small part of it can always be saved and invested for the future. So now, basically, financial planning and certain steps to be followed. You might not follow these in the same way, but I would like to give some guidance on the same. So first point is setting financial goals, management of debt, tax planning, insurance and risk management. Then you need to find out certain investment strategies and where to invest. And then last but not the least, retirement planning. So let's start with setting financial goals. As far as setting financial goals is concerned, I think everybody has different goals in life, financial as well as personal. So what we need to do is, for each and every person, either you are, if you're not married, then you would be having certain personal goals, long term, short term, career wise, where you want to see yourself in life later on, how much money would be needed, who all are dependent on you financially. And in case you're married, then you would obviously be, I think you should take into account the goals of your partner as well. So in case she's also a doctor or a practicing doctor, then I think the goals would be similar, but obviously you can plan a little more considering two streams of income. So the basic thing about goals is that they should be clearly set, first point. Secondly, as far as our goals are concerned, we should know the timelines, when what needs to be done, or when we want something in life. Let's say I have a child and I'm planning to earn, to invest, to save some money for his higher studies. So that way we can fix some timelines. Let's say when he's 18 years old, I need this much money. When he goes into post-graduation, I need some more money. So we have to see the timelines, and accordingly we can later on find out the strategies as to how we need to invest and where we need to invest, considering the return of income on different things, and how much time would it take from those instruments and from those strategies to reach my goals. So those need to be set very clearly in the beginning itself, so that you really find a comfort zone for you and you can make a plan to go ahead. Whether in the beginning, if you don't have money, too much money, then you can obviously start low, and then you can think about it, forecast it, how you can increase the investments. Then we basically need to, like I said, we need to execute those strategies to reach our goals. And last but not the least, once we have started with the executions, and once we have sort of got into the habit of investing and saving and putting our money into various kind of instruments, we obviously need to have a timely review of whether the goals are being achieved, or are they on the path of achieving the goals. If not, then obviously we can revise our goals. We can also revise the strategies that we have undertaken. Maybe some of them have become obsolete. Maybe some new kind of strategies have come which would bear us more returns. So that is basically the process of setting goals for our own financial planning early or in our career, so that later on we can have a more comfortable life without the stress of any finances. Now, the next step is debt management. As we all know, the cost of education is very high in the country. So many of the professionals, they have surely taken educational loans for their studies. And later on, if you start your own practice, you start your own clinic, sometimes if you are buying a real estate, we have to take debt for that also. Debt means loans. So basically, debt is very easily available to professionals these days because of the high cash flows or regular cash flows, and the you can say the trust of the financial institutions in the professionals. Plus, personal loans are very easily available for a short term and for a small amount. So it becomes very easy to take loans. However, it might turn out to be a trap where we say, okay, funds are available, debt is available, let's take it and invest it somewhere. But in case the returns are not as such, and if we have not properly budgeted our cash flows for it, we might face day-to-day problems in either meeting our expenses or saving for other things. And in case we are not able to repay the loans, then there might be high interest rates, penalties as well. So all in all, it becomes a mental and financial burden. So debt management is very necessary. We really need to budget how much cash flow is coming in, how much of the EMIs and interest we have to bear, how much time will it take to repay it. So, and the main things that we need to keep in mind are that we should always repay our educational loans and then only go ahead for the other loans. And secondly, our day-to-day expenses should always be kept in the budget before taking on new debt for which you are not able to generate cash or you're not able to generate finances. Then your day-to-day expenses should not suffer. Secondly, as far as your financial milestones in your life are concerned, just like I said in goal setting, as per your goals, in case debt is required to be generated to invest in certain instruments or into real estate or anywhere else, then it should also be planned into your goal settings itself, so that you really do not have to plan for it later on with your finances. And it's already been taken care of, it's already been budgeted. Also, there are certain refinancing and prepayment options. Let's say if we get a good stream of income, let's say we had not expected it, but we get a lot of income some years or some. So we should plan prepayments accordingly. We should not put all of that money into repaying the loans, because the loans might not need repayment at that point of time. That money can always be used to invest somewhere else, which might give you more better returns than the rate of interest of the loans. So that kind of planning should also go hand in hand with your long-term planning. Now, one of the very important aspects of the whole financial planning is tax planning. Now, we see taxes are to be paid on all sort of incomes, and they are a very important part of our whole financial ecosystem. So you can't really get away from the taxes. They have to be paid on each and everything. So in case a professional is into his own practice, then the net income of a professional is subject to tax. In case of salaried professionals, the employers usually deduct the tax on the taxable salary that they give to them. So they really cannot budget for it. It is already deducted. So you get the cash in hand salary itself. And the other income streams like dividend, interest, etc., they are also taxed at a different rate sometimes, but majorly at the same rate of tax only. Further, a very important thing is that there is no GST on medical profession as such. However, if you are into your own practice, sometimes doctors have a pharmacy along with their clinics that is subject to GST. Sometimes they have a diagnostic lab that is also subject to GST. So you really need to plan for that. However, GST is an indirect tax, so sort of it does not affect the income stream or the cash flow as such. Now comes taxes on real estate. So whatever we invest in real estate, the taxes basically come when we sell the properties. So that is taxed at a lower rate of tax. However, the rental incomes are taxed on a regular basis at the regular rate of tax. However, there are some deductions which can be claimed, like you can claim your property taxes. So thirdly, whenever you sell or purchase a real estate, you have to pay duties. So that also needs to be factored in the overall rate of return from a real estate. Sometimes we don't sort of budget for the duties that have to be paid on the sale as well as the purchase of the real estate. So sometimes we might not feel short on money. And major deductions that are available to medical professionals are that all the expenses that you do for your clinics are deductible from the revenue streams that you have. And medical and life insurance is also a deductible expense. Then loan repayments and interests, if taken on your house, is also deductible. Then personal investment like mutual funds and stocks, they are taxed at a lower rate of interest. So they would obviously form part of a tax planning wherein returns are higher and taxes are low. So it sort of puts more money in your pocket. Then comes risk management. Now, the kind of risk that doctors face are of two types. One is the personal risk and the second is a professional risk. Now, personal risks are of maybe 2 or 3 categories wherein you may say that you may fall ill. Obviously, I know doctors treat others, but doctors also fall ill. So that is also a health risk for them because they are dealing the whole day with sick people. Sometimes they also get sick from what I gather. So, and crucially, if you are falling ill with a critical illness, then you obviously need to have a medical insurance. So that is how we mitigate the personal risk. Then there is a disability risk. If somebody faces an accident or something, then I think adequate planning needs to be done for that also by taking an adequate critical illness insurance. Then the third risk is risk to life. which is common for everyone. So life insurance is a must to be taken so that your family, your dependents are taken care of in case you're not there. Secondly, in case you have undertaken any debt, let's say for a house or for a clinic, then that debt, the life insurance should at least cover your pending debts, so that after you're gone, your family should not have to think about repaying all those loans. They're clearly paid out of the life insurance itself. Then comes the professional risks. These days, there are a lot of legal cases which are being floated against the medical fraternity as well. So I think a professional indemnity insurance has also become very important, so that losses are not faced, unforeseen losses are not faced in the practice. And the second kind of risk is the risk to property, wherein there might be a fire or a burglary at your place of work. So it should not put any additional burden on you to pay for that, or to find out, to look for money, or to arrange money for that. So there's just to mitigate all kind of risks and losses associated with them. So insurance of all kinds is very necessary. Now we come to a very important portion, which is the investment strategy. Like, first we have done the goal setting, then we see how to budget for that, whether it is through debt or through income. How do we find the money to invest? Then we find out how to reduce our risk, how to save money. And last but not least, all that planning has come to the main point wherein we are executing what all we have, sort of goals we have set, or the planning we have done. That comes from investment strategies. So investment strategy is directly linked with the kind of planning that we have done and the kind of risk that we are willing to take. So there are different kinds of investments that we can look for. Some of them are fixed income, wherein we come to debt funds, fixed deposits, which give us specific rate of interest every year, and it's fixed. Then comes high risk, which are stocks. Then there are equity mutual funds, cryptocurrency, as you might be knowing, Bitcoin. So these are very high risk. You never know whether you have put in 100 rupees, whether you will get back 300, or you might not even get back 50 rupees. So these are usually high risk, but the rewards are also very high. So these should, in case you are pretty young, then you should keep a higher portion of your money in the high risk category and a little lesser portion in the fixed income category, because we still have fixed income flow which is coming in, and we can take risk early on in life, so that obviously the rewards are also high. And you can always think, and you can take help from professional financial planners in which stocks to invest in, which equity mutual funds to invest in. And if you invest for a long time, like I said, long-term wealth creation, if you invest for a long time, you are bound to have good returns on this category of high risk investments. Now we come to long-term wealth creation, which can usually be done from real estate, gold and silver, but they are obviously high ticket items wherein you need a lot of money to invest at the upfront. So either you have to go for debt, or you have to have a lot of savings. And then comes long-term mutual funds, wherein you can obviously invest a very small portion every month. So it is one of the easiest long-term wealth creation aspect. However, you really have to choose the mutual funds in which you are investing. So for that, a little bit of study is required. Then it is very important to have a certain corpus for emergency funds, which might be somewhere, let's say, 6 months to 1 year of your requirements for expenses. And that should basically be into something liquid, which is like FDs, bank balance, or cash, so that as soon as you need them, they are readily available to be used. Obviously, mutual funds and stocks are also liquid to a certain extent, but they still take 5 to 10 days to receive the money. And whereas FDs, bank balance, and cash, this is very liquid and you can use it the next day you need it. So some sort of emergency fund should always be available with everybody. Then comes regular income, which is like rent from real estate. This is a different category wherein you really need a lot of money to be invested to get regular income. You can always keep it a part of your long-term goals. so that later on in life, there is another income stream where you don't have to really work hard for it to earn money, and you have ready cash available in your hand every month, which can be used for all sort of goals. So basically, the investments should not be put into one category all at once. It should always be diversified, a little bit there, a little bit here. It should always be based on your risk profile, how much risk you're willing to take, how much returns you are expecting, and how early or how late in life you need the money. So basically depends on your goals and your risk profile. Now comes retirement planning. This is coming at the last, but it is also a very important part. However, I feel that people in the medical profession, they do not really retire very soon, because like all professionals, we can keep working till late in life. It does not make any difference. However, I would say a little bit of retirement planning is still needed, so that our mental abilities are not focused towards earning money at that point of time in life, and service of profession is basically done for the passion of it. So certain kind of retirement planning is also important for medical professions, wherein, let's say, a part of the retirement funds should be in a corpus, wherein you have a bunch of money which you can use for unforeseen circumstances, or let's say critical illness, or anything else that you need the money for. Secondly, when you grow old and you're not earning that much, then it helps to meet the day-to-day expenses. There should be a regular income stream as well from that corpus fund. Thirdly, it helps in being self-reliant. You are not dependent on anybody. In fact, you can help the others. Now, the kind of investments that can be done for the retirement planning are basically, you can put your money in pension funds, wherein a regular amount of pension comes to your account. Later on in life, let's say after 6 years of age, you get a regular amount of income from the money that we are investing per month right now while we are working. So we are not allowed to take out that money. But later on in the life, when you grow maybe 60 years or older, that money automatically starts coming back to our account with the returns. Then we can have some fixed deposits, like I talked about earlier, to have something in liquid. Then real estate, obviously, if we are able to manage it during our heydays, then real estate as an investment really helps for retirement planning. So like we can sell it off, or we can put it on rent, and we can obviously have a regular income stream even when we are not working. Then some amount can always be put into the national pension scheme, which also gives you a regular rate of return whenever you want it after you grow old. So these are basically the major points which everybody should be aware of. I have tried to sort of make everyone aware of the kind of planning that needs to be done, so that whenever somebody talks about it, doctors should not feel that we don't know anything about it. So obviously now you got a talking point wherein discussion can be started, and obviously doctors, the kind of investment decisions that I have seen doctors do it is basically through suggestions from their peers. Even peers are also not aware too much. So whatever happens is through a reference or something. Sometimes they end up making bad investment decisions. So as long as you are aware and you really want to learn what is the rate of interest, what is the kind of returns that a particular instrument is giving, or a particular investment is giving, what is the kind of real estate should we invest in, or should we at all times invest in real estate only, which is the case with doctors, because it looks like a safe investment. However, sometimes it so happens that it does not give the kind of return that is expected. So we should not fall into the trap. We should always have a diversified portfolio wherein we put our money into everything. We understand that regular income, whenever it's coming, it's very easy to spend it all. But a little bit of awareness and a little bit of understanding about your finances can go a long way, and it will always have you save some money for the later on days in your life when we are not working. So that is all basically what financial planning is all about. So I would like to summarize now. It's basically, it's like the doctors diagnose the problem and then prescribe appropriate medication rather than relying on over-the-counter remedies. In the same way, each and every person has different goals in life, and their financial planning needs are also different. So they should basically study their own temperament and then make plans for their retirement and financial planning so that it suits them, and it's very easy to follow if you get into a routine. So that is what I wanted to convey today. Hope I have been able to give some new insight, and thank you very much for giving me this opportunity. I'll just see how to stop.
Yeah, thank you, Mr. Garg. I think this was a wonderful session by you. I think there are lots of questions, but one or two things I would like to clear myself. You didn't so that the doctor should go for the share market investment. So what is the first take up for us better? Should doctors also go for the share market investment or not?
Yes. I discussed about it. I called them stocks. So maybe
That's a stock, yeah.
what you confessed, I should have said equity shares. So doctors should obviously go for stock market options, but I would suggest that they take the help from certain financial planners who have more knowledge about the companies in which to invest in. And secondly, since doctors do not have too much of time to understand the stock market on a day-to-day basis and to take decisions as and when the stock market changes, so they should go for good companies and they should go for long-term investments. I would say for 5 to 10 years, if you invest in any stock, it is bound to give you returns of somewhere around 15% if they are good stocks, which is not possible in any other investment. So stock market is a very good way to multiply your money. However, it needs a certain discipline and it needs a certain routine. If you keep investing small chunks of money on a regular basis and through some help, so through some professional help, then I'm sure it would give you returns much more than any other form of investment, even real estate.
Second thing, very important and burning topic with the doctors is about the GST. So sometimes, well, if I am suppose a private practitioner, I am doing a single clinic. So but I have lots of relationship as an advisor with some pharma companies. So pharma companies are taking our advice and giving some advisory. So we get checks from that. So I think the rule is that if it exceeds more than 20 lakhs per annum, doctors would file a GST. So is it true or not?
Yes. Doctors have different streams of income. Let's say one stream of your income is from your medical profession, your practice, or the money that you get from hospitals through OPD or whatever. The second stream of income might be through your honorariums or from the advices that you give to pharma companies. So I also talked about two more income streams. Let's say you have a diagnostic lab, or you might be having a pharmacy near your clinic, which might be owned by you. So only the receipts from your medical profession or your medical practice is exempt. So as far as that might go into crores, even on that, there is no GST. But as far as all the other three aspects are concerned, in case they exceed 20 lakhs for 1 year, then you have to go in for GST. However, your medical profession revenue will still not be taxable. Only these things will be taxable under GST.
Well, you mean that even suppose in my lab, if I run a small laboratory and doing simple tests, but it comes more than 20, if the income is more than 20 lakhs per annum, then it should be go for the GST or even below 20 for the small labs. If he is doing in the OPD, suppose in the OPD, some doctors are doing some tests, like blood sugar, they are doing, glycated hemoglobin are doing, or other things are doing. So should we take a GST for that also?
I think if it exceeds 20 lakh rupees, then it has to go for GST.
If it exceeds 20, more than 20, then
yes. If the receipts are more than 20, then only you have to go for GST. The same is with the pharmacy business. You have to go for GST in there.
Dr. Amit or Dr. Preeti?
As on day-to-day basis, it is very difficult for we doctors to chase the share market.
Yeah.
Right.
Is it safe if you have got some money to put in the mutual funds? and
Yes,
need not
it
to
is.
chase again and again.
No. The option of mutual funds is a good option because you don't have to chase it on a day-to-day basis. A mutual fund has the corpus of money which is managed by professionals. So as far as that is concerned, you can always study, or you can ask your financial advisor, whoever is helping you invest into mutual funds. You can ask them about the top 5 or top 10 mutual funds. You can always distribute your money accordingly. Mutual funds have certain kind of options wherein you can go for debt funds also, which have a fixed rate of return. They are not very risky. They do not change their rate of return on a day-to-day basis. Then you can go for mixed funds, which have certain portion into debt and certain portion into equity. Or you can go into 100% equity funds, which also have different categories wherein some of them are blue chip companies, some of them are middle companies, some of them are small companies. So as far as your risk profile is concerned, you can, if you can't chase it day to day, or if you do not even want to review it on a regular basis, let's say 1 month, 2 months, or 6 months, then you can obviously go for long-term
Means in comparison
mutual
to
funds.
shares, mutual funds are relatively
Safer.
safe.
Yes, yes, you can say that. You can say that. You do not have to, as far as the investment and the sale of shares is concerned, that is all taken up by the mutual fund company itself. You basically have a share in the profit that they are making. So it is relatively safer. However, it is, at the end of the day, it is dependent on the stock market. If the whole stock market will go down, if there is a slump, then the mutual funds are also bound to go down. However, what we have seen is on a 10 to 15 years horizon, they are bound to give you a 10 to 12 to 15% return any day. And obviously there can be windfall gains also in case the stock market goes high. So I think a little bit of money should always be put into mutual funds so that we do not miss out on that opportunity. Even if we can't track it on a day-to-day basis, even if we do not have any knowledge of that field, but still we should go on the safer route, and we should mix and match, and we should make a portfolio, and we can always review it on a yearly basis if you want. And you can always change mutual funds which are better performing next year.
Can I buy shares from the Google or the Microsoft which are listed in US?
Yes, now you can. There is a scheme of the central government wherein they call it the liberalized remittance scheme, wherein you can invest into equity shares of overseas companies, whether through stock exchanges or otherwise. It is
Can
somewhere
you elaborate a bit more?
Pardon?
Can you elaborate a bit more?
Yeah. Up to $250,000 a year, the central government, it allows you to invest into equity shares of overseas companies. So even if they are listed, then you have to go through a broker. Usually these days, all the major brokers, they have tie-ups with brokers in the US, or let's say in Japanese stock markets or in the Singapore stock markets. They have tie-ups and they can very easily help you open an account over there. However, from what I gathered last time that I inquired about it, they had a certain minimum criteria of investment which they want you to meet. Let's say they will ask you to at least invest 20 lakh rupees, or maybe $10,000 or $15,000 to start with, because lower than that they do not want to deal with all the compliances and everything. But obviously,
and how do we what is the taxation on it, and how do we sell them?
The taxation is similar. As far as a person is resident in India, all his income will be taxable in India only. However, the benefit of a lower rate of taxation will not be available to overseas investment in equity shares. Like in India, if you invest in the stock market, your long-term capital gains are taxed at 10% and your short-term capital gains are taxed at 15%. However, if you invest in overseas stock markets, all your gains will be taxable at the slab rate that you are appearing in, let's say 30% or 20%, whatever is your income, it will be taxed accordingly. So that
so
benefit
you mean to
is
say,
not available. Yeah.
I'll
Pardon?
be paying the taxes in the US also as well as in India also?
You will be paying tax on any and every kind of income that you are earning. As long as you are staying in India, you have to pay tax in India only. In case you are paying any tax in US also, then the government always gives you a benefit. They give you a relief in tax. for the taxes that you have paid outside India.
Thank you.
You're welcome.
I think, Siddharth, it was a very, very informative session. And many of us were glued to the screen. And it was a very, very comprehensive presentation. Dr. N.K. Singh, if you want to ask anything more, you can ask Siddharth. Or if there are any other questions, Dr. Preeti.
I think there is nothing in the chat box, Amit. So I think Mr. Garg has explained very well. And Dr. Goyal has been given also a very important and very rare case today. I think everything is done. You can actually end the session also if there is no any question further.
Right.
Yeah. So you can go for the vote of thanks.
So I would like to thank Dr. N.K. Singh, Professor Dr. V.K. Goyal, Mr. Siddharth Garg for honoring the ACP India chapter platform, coming here and speaking on your expertise. And I think all the viewers must have found it very, very useful. And there are certain episodes which actually make a deep impact. And I think both the case as well as the financial aspect will be viewed by our viewers again and again when we will post it on our website also. Thank you, Dr. S.K. Gupta, for joining. I know you have just returned from the Geneva meeting of the World Health Organization.
Congrats to him. Yeah.
And congratulations to you for representing India there. And a big thanks to our governor, Dr. Anuj Maheshwari, who has taken this program to a new height. And now we are entering into the third year of the ACP India case files. And many, many thanks to Dr. Preeti Singh. Dr. Preeti is, she is the HOD of medicine at AIIMS Bhatinda. She was not keeping well today, but she still coordinated each and everything so perfectly. Good. And we are really very, very thankful to you, Dr. Preeti, for conducting the ACP India case files for almost like last 5 to 6 months on a regular basis and coordinating each and every aspect of that. So we will be back again next month in the last week of the June when we all return from the ADA with another episode of ACP India case files. So thank you very much. And the last words from the Dr. Preeti. Yes.
Thank you, sir. Thank you so much. We now come to the conclusion of today's session and looking forward to many such intellectual feasts in near future. Thank you so much.
Thank you. Thank you, everyone. Thank you for that.
Thank you and good night.
Good night.
Good.